Lecture 3, Laryngeal Endoscopy. Laryngeal endoscopy is used to view the anatomical structure and gross function of the larynx, and if stroboscopy or high-speed video are used, the vibratory characteristics of vocal fold vibration can also be assessed. There are a number of techniques used to visualize the larynx and vocal fold function, and these are laryngeal mirror exam, transnasal flexible exam, oral endoscopy with a rigid scope, video stroboscopy with a flexible or a rigid scope, high-speed video endoscopy, and video chymography. The laryngeal mirror exam was developed by the well-known opera singer and singing teacher Manuel Garcia in the 1850s. It soon became the standard of care for examining the vocal folds. Some ENTs still use the laryngeal mirror exam to obtain a gross view of laryngeal structure, anatomy, and gross function. However, assessment of the vocal fold vibratory characteristics is not possible with the laryngeal mirror exam, and diagnosis should be confirmed by endoscopic exam, preferably video stroboscopy. This is a photo of a laryngeal mirror. Transnasal flexible endoscopy is used in the laryngologist's office. It can be used with or without a video stroboscopy unit. If used without video stroboscopy, only gross laryngeal anatomy and function can be assessed. Vocal fold vibratory characteristics cannot be assessed without stroboscopy. Prior to passage of the flexible endoscope through the nasal cavity, a topical anesthetic may be applied as well as a lubricating gel to help ease the passage of the scope through the nasal passages and decrease any mechanical discomfort experienced as the scope is passed. Patients are awake and typically do not experience pain. The flexible fiber optic cable transmits the halogen or xenon light source to the tip of the scope for illumination of the larynx, and the lens carries the image to the camera. Some newer scopes have a digital chip camera at the tip of the scope, which provides greater magnification and better light. One of the benefits of using a nasendoscope is that it allows for laryngeal function assessment during complex tasks such as speaking and singing. We can also assess for possible laryngeal muscle tension by observing position and posture of the supraglottic structures. Drawbacks to the nasendoscope include less illumination and magnification than for the rigid scope, as well as possible image and color distortion. Nasendoscopes with the camera and the scope tip have greatly improved magnification, illumination, and color, but they are quite expensive. This shows you an illustration of a transnasal flexible scope. The rigid endoscope consists of a long metal tube slightly thicker than a pencil. At the tip of the scope is a lens. The light source is carried through the attached fiber optics cables and is emitted from the tip of the scope. The lens at the tip of the scope and the camera at the far end of the scope picks up the image of the larynx, and the image can then be viewed on the video monitor. The rigid scope has excellent magnification, illumination, and color. However, the patient is only able to produce sustained vowels, and the likelihood of a gag reflex is much greater with the rigid scope than with the nasendoscope. If gagging is a problem, the ENT will typically spray the oropharyngeal area and sometimes the base of the tongue with a topical anesthetic to eliminate or decrease the gag reflex. This is a picture of a rigid scope, but it is attached to an older style high-speed camera. Video stroboscopy has become the gold standard for laryngeal examination and diagnosis of voice disorders. The primary purposes of a video stroboscopic exam for the ENT are to obtain or confirm the medical diagnosis and to assess the extent and effects of the voice disorder on vocal fold vibration. According to Carnell, the primary purposes of a video stroboscopic exam are to ID the physiological correlates of the perceived resonance in voice quality, document the status of laryngeal anatomy and physiology during speech production, and assist educational and clinical discussion. Secondary purposes are to confirm the diagnosis and improve patient motivation and counseling. In our clinic, we always show patients their exam and explain the vocal pathology and its effect on normal phonation. It helps patients understand their disorder and helps with compliance. Video stroboscopy can also be used for biofeedback during therapy. However, the patient must have a good tolerance for the scope and a low gag reflex for this to be successful. Video stroboscopy provides us with information regarding normal vocal fold vibratory characteristics, vocal fold pathology, and the resultant effects of the voice pathology on vocal fold vibration. This information helps us to develop and tailor our therapy plan specifically for a given patient. Video stroboscopy also provides a permanent record for pre- and post-therapy comparisons. I frequently recommend that professional voice users, such as singers and actors, obtain a video stroboscopic exam when they're vocally healthy as a record for comparison if or when they ever develop vocal problems. In order to perform a video stroboscopic exam, one must have a video stroboscopy unit. This consists of a computer with the appropriate software, a computer monitor for video playback, the light box with both halogen and xenon light sources, a camera that attaches to the end of the scope, unless of course you have a chip in the tip scope, and a laryngeal microphone or electroglottography. Video stroboscopy uses a light source that is pulsed for endoscopic visualization of vocal fold vibration in apparent slow motion. The source of the pulsing light is a xenon bulb in the light box. The laryngeal microphone or electroglottography unit tracks the fundamental frequency of the patient, and the light flashes at 1 to 2 Hz above the fundamental frequency, and this results in apparent but not real-time vocal fold vibration. This is called the normal phase. The illustration in the slide shows you 4 cycles of vibration. The vertical arrow shows where in each cycle the light will flash and the picture will be taken. The individual pictures are then combined together via a computer software program to comprise 1 cycle of vocal fold vibration. Remember that this 1 cycle is actually composed of specific sections of many cycles. Thus we are not seeing true real-time slow motion vocal fold vibration. We are seeing what we call apparent vocal fold vibration. Still, this is very useful and it's a good method of laryngeal examination. One drawback of stroboscopy is that if a patient's vocal fold vibration is moderately to severely aperiodic, the software will have trouble tracking the fundamental frequency due to the aperiodic vocal fold vibration, and the stroboscopy image will not be as clear. The stroboscopy image depends upon accurate tracking of the patient's fundamental frequency so that the light can flash and the picture can be captured at the appropriate times, 1 to 2 Hz faster than the patient's fundamental frequency. If the FO is varying, then it will be difficult for the software to track the fundamental frequency and determine when to capture the image. Locked phase is used during stroboscopy to assess the periodicity of vocal fold vibration. During locked phase, the light flashes and the camera takes a picture at the same point of every cycle of vibration. The illustration in this slide shows 4 cycles of vibration. Notice that the vertical arrows are at the same point for each cycle. If the vocal fold vibration is periodic, then the vocal fold should appear to stand still when the image is produced. If not, the vocal folds will move about. For example, if the picture is taken at the same point of each closed phase of vibration, then the vocal fold should appear closed and still if vibration is periodic. When performing a video stroboscopic exam with a rigid scope, the patient will only be able to produce sustained vowels. The tasks we use for assessment are outlined in the slide. Typically, we begin with the bright halogen light in order to assess laryngeal anatomy and gross movements of the laryngeal structures. We then switch to the xenon or strobe light to assess vocal fold vibratory characteristics. Deep sniffs show vocal fold abduction, while short E, then sniff, shows alternating vocal fold adduction and abduction. When using a transnasal flexible endoscope for video stroboscopic examination, we use the same task protocol as for the rigid oral scope, plus we ask the patient to talk and count, etc. If the patient is a singer, we will always have them sing. With a flexible scope, we can even administer therapy probes to see if specific therapy techniques will be beneficial. There are many anatomical and vibratory characteristics and features we assess during a video stroboscopic exam. This slide lists the vocal fold features and vibratory characteristics we evaluate. We will discuss each one in the following slides. Assessing the type of glottic closure is very important. Glottic closure is assessed during the closed phase of vibration at comfortable pitch and loudness. This illustration shows a number of different types of glottal closure. In the center, complete glottal closure is shown, and to the left of center is a posterior gap. These two types of closure are normal. In fact, approximately 25% of women will present with a posterior glottal gap. To the right of center is bowing. This is not normal, but may be observed in Parkinson's patients and presbylaryngeus, which is aging voice. The top left shows a longitudinal gap, which may be the result of vocal fold paresis or paralysis. The top right shows an anterior gap. Most laryngologists feel that this is likely indicative of laryngeal muscle tension. The bottom left shows irregular closure, and the bottom right shows an hourglass closure. Hourglass closure is very typical for vocal fold nodules. An abnormal glottal closure pattern can result from poor vocal fold adduction due to recurrent laryngeal nerve damage or cricoarytenoid ankylosis, which is fixation of the cricoarytenoid joint, obstruction due to a vocal fold medial edge lesion, laryngeal web, laryngeal muscle tension, granuloma, or reduced tissue pliability due to scarring or sulcus vocalis. So there are many reasons why we might not get complete glottic closure. We also evaluate supraglottic activity and look for signs of laryngeal muscle tension in the form of anterior-posterior compression, medial lateral squeezing, false vocal fold adduction, or supraglottic sphinctering. We also assess the vertical level of the vocal folds. Both vocal folds should be on the same vertical plane. If one vocal fold is lower than the other, it may indicate an SLN paresis or paralysis. We also assess the medial edge for smoothness or irregularity and rate the severity and location of the irregularity. Irregular vocal fold edges occur due to medial vocal fold edge lesions, vocal fold scarring, and edema. It is particularly important to rate the normalcy and extent of the mucosal wave and amplitude of vibration. This is always rated during phonation at comfortable pitch and loudness. The reason for this is that high-pitched phonation results in thinner, stiffer vocal folds, and the mucosal wave and amplitude of vibration are normally less for high pitches than for comfortable pitches. The mucosal wave or traveling wave excursion is typically 35 to 60% of the total vocal fold width. A decrease in mucosal wave excursion or absence of mucosal wave is seen in cases of decreased tissue pliability, such as scarring, mass lesions, sulcus vocalis, and mucosal dryness. The wave also may be increased, as in cases of polypoid degeneration. The decrease in the wave may be confined to a segment of the vocal fold or occur across the entire vocal fold. Phase symmetry is the measurement of the degree to which the vocal folds mirror each other during vibration. During vibration, the vocal folds should close and come to the midline together. If one lags behind the other, they are out of phase, and we call that phase asymmetry. Phase asymmetry may result from differences in vocal fold mass, length, or tension, which result from unilateral vocal fold lesions, unilateral neuropathy, or unilateral differences in tissue pliability. When we observe phase asymmetry in the absence of these circumstances, the clinical relevance of the phase asymmetry is uncertain. However, many laryngologists, ENTs who specialize in voice only, believe persistent phase asymmetry may be related to laryngeal muscle tension. Phase asymmetry at the onset and offset of phonation is not unusual. Phase closure reflects the durations of the relative open and closed phases during an observed vibratory cycle. At comfortable pitch and loudness, the open phase may account for 40 to 60% of the vibratory cycle. If phonation is loud, the open phase will be shorter and the closed phase will be longer, 70 to 80% of the cycle. A vibratory cycle that is predominantly open phase is typically associated with a breathy quality due to incomplete glottic closure. Voice disorders that result in vocal fold weakness, such as paresis or paralysis, result in longer predominant open phases. Conversely, a vibratory cycle that is predominantly closed is often associated with depressed vocal quality due to laryngeal muscle tension dysphonias that result in hyperreduction and foreshortening of the vocal folds. Variations in subglottal pressure, intensity, vocal register, pitch, and vocal effort will also affect phase closure. We also assess vocal fold mobility. The vocal folds should abduct and adduct together, that is, mirror each other as they open and close. If one side is lagging behind the other during abduction or adduction or both, it may indicate laryngeal weakness. This is easily assessed by asking the patient to take several deep sniffs, during which the vocal folds should maximally abduct together. The sniff E task, E, E, repeated several times, will show alternating abduction and adduction. Vocal fold stiffness manifests as a lack of mucosal wave and decreased amplitude of vibration. A regional absence of mucosal wave along with absence of vibratory amplitude is called a non-vibratory segment. We always note vocal fold stiffness and the location of the non-vibratory segment in our report. High-speed video endoscopy was first developed by Bell Laboratories in 1937. High-speed endoscopy gives us a great deal more information than video stroboscopy. Because the apparent vocal fold vibration observed during video stroboscopy is composed of sections of successive vibratory cycles, data is lost during the procedure. High-speed endoscopy gives us detailed information for every individual vibratory cycle in slow motion. So why don't we use high-speed clinically? Early on, high-speed video required a large camera, a very bright light source that generated a lot of heat, and data analysis was time-consuming. In addition, the procedure had to be short due to the heat generated by the bright light source, or the patient could be burned. For many years, high-speed video has been used primarily for research, which has provided us with a better understanding of the finer details of vocal fold vibration that could not be obtained via video stroboscopy. Over the years, advances in technology have made high-speed video less cumbersome and the light source somewhat less hot. High-speed units are now available for clinical use and are used by some laryngologists in place of video stroboscopy. The clinical application and use of high-speed in our field will most certainly increase in the coming years. Laryngeal endoscopy. Be sure to watch the normal video stroboscopic exams posted on Moodle. Download and take a look at the stroboscopy rating and report forms on Moodle. Try rating some of the normal exams and using the rating forms. I'll post the ratings key on Moodle. And be sure to watch the endoscopy information videos as well.